a reminder, exam 3 in 2 weeks is not a cardiac exam. Exam 3 in 2 weeks is not a cardiac exam. So the infectious diseases, structural disorders, and arrhythmias are just part of that exam. Are we clear? Right. So don't kill yourself studying dysrhythmias. All right. There are other questions. So this is just one topic. This can have up to 15 questions on that exam. So 35 other questions are on other topics. Are we clear? All right. So don't go crazy. So I mentioned that there will be strips on the exam, only the ones found in your textbook, right? For fairness sake. And when I say dysrhythmia, if there's a strip question, I can ask 5 possible questions on each strip. 1, what is it? What is that rhythm? 2, what causes it? 3 is the easy part because there's the third question is signs and symptoms. Now, is there an abnormal heart rhythm that increases cardiac output? Is there an abnormal rhythm that increases cardiac output? Which one?
It's just gonna be beating faster, but the output is not.
Remember, what is the PR interval again? What is the significance of the PR interval?
Everything
From the T to the QRS.
Yeah, so what's the significance? Why does it have to be 0.12 to 0.2 seconds? Okay, so PR interval tells us that the ventricles are filling with blood. Okay, so it should be 0.12 to 0.2 seconds, correct?
Yeah.
So if you say ventricular tachycardia, the proventricular tachycardia, or even sinus tachycardia, what happens to the PR interval? Because if you're gonna stack same 6-second strip, but now you're stacking a lot of heartbeats in there. So what happens to the PR interval? It narrows, it shortens. So what happens to ventricular filling time? What happens to cardiac output? So is there ever a dysrhythmia that will improve or increase cardiac output? None. So therefore, what will be signs and symptoms of any dysrhythmia?
Decrease cardiac output.
Same. Remember heart failure? Okay, so signs and symptoms of left side heart failure, because left side heart failure leads to decreased cardiac output, correct? So will the manifestations be different?
No.
Same exact idea. Are we clear? So the third question is the easy part because there will be signs and symptoms of decreased cardiac output. The severity will vary. Some dysrhythmias are more serious than others. All right? Okay. Fourth question is, what do we do about it? The interventions will be pharmacologic or non-pharmacologic. Number 5, last question is teaching. What do you teach the patient? Of course, when we teach, what will we teach the patient about a dysrhythmia? Causes, correct? Let's say smoking or coffee or energy drinks causes. What will you teach the patient? Keep drinking them. Yeah? Okay, so of course you teach them to avoid these things, all right? And then what else do you teach? What do you do when you experience them? Yeah? And then finally, what do you teach them about the medication? How do these medications work, okay, to treat your dysrhythmia? All right, so 5 questions. What are they again? First one,
What is the strip?
what is this? What strip is this? What rhythm is this? 2, causes. What are the causes? We need to know the causes so that you know, correct, prevent and treat it, because not all dysrhythmias require treatment. It really depends on the severity of a dysrhythmia. Third, signs and symptoms. Fourth, what do we do about the dysrhythmia? 5, teaching. Okay, so if there's none on your textbook, so if I were you, you make notes, you create your own table with 6 columns. First column, the dysrhythmia, and then the 5 will be those 5 questions I could ask. All right, and then row by row, list down your dysrhythmias. Yeah, it would be nice if the textbook did that for you. Yeah.
Or you can do it.
Well, it's not gonna be free. If I do that, it's gonna be for sale. Okay, before we can analyze abnormal rhythms, let's look at what a normal rhythm looks like. So these are characteristics of a normal sinus rhythm. So you can call it normal rhythm, or the official term is NSR, normal sinus rhythm. So if the rate and ventricular and atrial rate are both 60 to 100, they're regular. Remember when we did the caliper? No, they occur about the same interval. Shape and duration, P waves normal, QRS normal, PR interval, normal duration, QRS same under 0.112 or less. There's a P wave always occurring before QRS, and 1:1 ratio, meaning 1 P for every QRS, 1 ST for every T. All right. If that's all met, normal sinus rhythm. Here's an example of a normal sinus rhythm. So nothing to do here because this is normal, yeah? Okay, so will there be signs and symptoms? No, this is normal. Okay. So nothing to do. We're happy with normal sinus rhythm. We group arrhythmias into 2. We have sinus, we have tachydysrhythmias, and then we also have bradydysrhythmias. Let's first look at 2 sinus node arrhythmias, meaning these are generally normal except for the rate. The only thing abnormal with these 2 rhythms is the rate. But all the measurements, the P wave, QRS, PR interval, ST, T wave are all normal. What's the only thing wrong with these 2 rhythms? The heart rate. Okay. So you can call these 2 the evil stepsisters of the normal sinus rhythm. So sinus bradycardia, heart rate's less than 60, but all other measurements are completely normal. PR interval's okay, P wave looks normal, so is the QRS, so is the ST, so is the T wave. What's the only thing wrong here? The rate, only the rate. So what does it look like? That's what it looks like. Question number 1. Question number 2, what causes it? There's no table. Now you're wishing for tables and charts now, yeah? What the hell happened? Last semester, did you ever care for charts and tables? What's becoming of you? You are turning into nerds. Okay, so here are the causes of sinus bradycardia. So people like me who are athletically, you fit, yeah, thank you. I was looking for that word. So we have low heartbeats because our heart is so strong that it doesn't need to beat 60 in order to perfuse the entire body. It can perfuse the body with a heart rate of 50 to 60 or even less. So sleeping causes it, hypothyroidism, vagal stimulation. Vagal stimulation are the following. Whenever you hold your breath, activities that make you hold your breath, such as vomiting. Are you breathing when you're vomiting? Are you breathing when you're suctioning? Are you breathing when you're in pain? Okay, so anytime you hold your breath is a vagal stimulation. So giving birth to a turd, are you breathing? Holding your breath. What else? Yeah, bending down, okay? Bending over. Or let's say singing, okay? Singing like you're doing a Mariah Carey song, for instance, okay? You turn blue, yeah? Medications. So these medications here cause sinus bradycardia, etc. A heart attack. Okay, so this could be a very nice select all that apply question. I'll put this strip. Nurse knows that the following are possible causes of this rhythm. So I won't tell you the rhythm. So that's a 2-in-1 question asking you to identify the rhythm. And then the other part of the question is asking you to identify the causes. Yeah, select all that apply. Next, signs and symptoms. Now, the signs and symptoms are depending on whether or not the patient is tolerating it. Because people tolerate dysrhythmias differently. Some people with 59 heart rate is unconscious, whereas others are totally fine, even with a heart rate of 35. All right. So you treat based on the patient's symptoms. So here under management, what does that say? First statement. Okay, just like I said, depends on cause and the symptoms. Patients no symptoms. Do we need to treat it with medication? I mean, no. So what do? Find the possible cause. So you have the possible causes here. So can we look for the possible cause? Yeah, we look at it, and if possible, if we can afford to eliminate it, such as if it's caused by a beta blocker, can we hold the beta blocker? Okay, can we adjust the dose, lower it maybe? Okay, right? So and so on and so forth. All right, what's the management again? Depending on the cause. If is the patient symptomatic? So let's say the patient has no symptoms, they're fine, they're running around, they're going about their business. Do they need treatment? No. All right. However, if they are symptomatic, meaning are they tolerating the rhythm? Obviously not. They have symptoms. So symptoms again is what? What's something common among all dysrhythmias? Symptoms of decreased cardiac output. So enumerate them again. Will I have shortness of breath? Am I lightheaded? Is my blood pressure low? Am I dizzy? Is my urine output low? So on and so forth. Okay, all signs and symptoms of decreased cardiac output. So if your patient is symptomatic, then you treat. What are the possible treatments? Okay, if eliminating the cause is not enough, then you have to give drugs. The number one drug of choice is atropine, 0.5 milligrams IV. You can repeat it, sinus bradycardia. You can repeat it every 3 to 5 minutes up to a maximum dose of 3 milligrams. So any drug that you can repeat every 3 to 5 minutes tells you what about this drug's half-life? Has a very short half-life. So it allows you to repeat the doses every 3 to 5 minutes. So what's the half-life of this drug, therefore? 3 to 5 minutes. Pretty simple, yeah? Okay. And if, let's say, they don't respond to atropine, then we'll have to go further. We have to put a pacemaker. We'll discuss pacemakers later because it's a whole section on pacemakers. So we'll come back to that. Any question on sinus bradycardia? Yes, IV push. Yes.
Patients are allowed to swim or not allowed to swim.
Patients who what?
It's either, but are they allowed to swim because they have to hold their breath to swim?
Again, it's not the only, it's not the only cause. I mean, you have to hold your breath at some point, yeah? When you give birth again, give birth to a third, which we do every day. So you have to, I mean, it doesn't, as long as it's, can you hold your breath forever? No. Okay, so that's fine. Okay. All right, next problem is, so you answered all 5 questions, yeah? Treatment and then teaching the patient, of course, avoid the possible causes, okay? And then if they're on medications, teach them about the medication. There's a chart for the medication, so we'll cover it later. Sinus tachycardia. This is the other evil stepsister. So this problem here is heart rate's over 100. So 101 to 120 is sinus tachycardia. Causes. Here are your causes. So anything that will trigger sympathetic stimulation, such as hypotension, anemia, low oxygen, low glucose. Okay, so these are triggers for sympathetic stimulation. So I won't read the whole thing. Here you have your list of causes. This is what it looks like. Again, the measurements are all normal except the rate is over 100. How do we manifestations? Again, depends. Some patients are symptomatic, some are not. So just like sinus bradycardia, what do you think is the treatment?
Stop whatever is causing. the heart
Okay,
rate.
so same thing as sinus bradycardia. Look at the possible cause and the symptoms. Is the patient symptomatic? If symptomatic, definitely we need to treat. No symptoms, try to eliminate the cause. So identify what's the patient's possible cause. Is it fever? Okay, is it pain? Because those are the physiologic stressors causing the sympathetic stimulation. Okay, so here's management. Again, identical with with principle. Okay, principle wise, same idea in sinus bradycardia. Identify and eliminate or abolish the cause and teach the patient to avoid them altogether. Since
Sinus tachycardia is determined by the severity.
all right, since vagal maneuvers were the cause of sinus bradycardia earlier, yeah? Okay, so therefore, do we want to lower this patient's heart rate? Yes, so the doctor can employ vagal maneuvers. Now, of course, they won't, cause constipation, okay? So we will mimic vagal maneuvers. So examples of vagal maneuvers is bearing down. So you'll tell the patient, okay, push, can you push? Now, it's not easy to do. Now, what they'll do instead is give you, a few activities in order to mimic holding your breath. So either give the patient a straw, okay, breathe through the straw, or we'll give them a 10 cc syringe, okay, blow through this 10 cc syringe, okay, so that's holding your breath, correct? Others, by the way, do not do any vagal maneuvers. Are we clear? The doctor will do this, okay? It's not safe to do vagal maneuvers because the heart rate may drop too low. And now you're responsible for that dysrhythmia. Are we clear? So only physicians, all right? So especially carotid sinus massage. So this is literally massaging the carotid artery. Now doctors only can do that. And when they do that, the patient must have a crash cart nearby. Because again, there are complications with these maneuvers. Heart rate may drop too low. Now we have to revive the patient. All right. Okay, so I won't read the whole thing. These are examples. Now, for adenosine administration, this is only reserved for a really high heart rate, meaning the patient has a sustained heart rate of over 120, 140, for instance, 160, or if it's already supraventricular tachycardia, wherein the heart rate's already 180 or higher, then we need to do heavy duty medication. Now, the only FDA approved drug to terminate SVT is adenosine.
That's the SC,
Sorry,
SVT or SC?
SVT. It can also be given for ST, sinus tachycardia, but the heart rate must be really sustained at 160 or higher. We employ other things first before we give adenosine. Okay. We'll look at the responsibilities later. This will be in another section. Okay. When we discuss adenosine, and I'll show you a video on how to use it. Other interventions are synchronized cardioversion. Again, this procedure, this maneuver is going to be discussed in a separate section and together with defibrillation. So we'll do that later. You're on page 697, yeah?
Yeah.
Okay, please follow with me because the Apple TV disappeared. So other interventions are, of course, beta blockers, calcium channel blockers. For catheter ablation, again, that's later in the chapter. We will skip sinus arrhythmia. It's not really very common. So we'll just stick with sinus bradycardia and sinus tachycardia. Any question on those first two dysrhythmias? Very good, children. Okay, let's go now to the atrial arrhythmias. Now there are four here. Let's start with a PAC. A PAC is a premature atrial complex. Generally speaking, these are harmless dysrhythmias. They occur. What are the causes mentioned here? Okay, so smoking. What else? Coffee is there, yeah? Okay, and then some stimulant drugs. Okay, so let's say you smoke crack, or let's say you sniff cocaine, for instance. So those can cause PAC, among other things. And that you have the figure there, figure 22-9. Now, a PAC is always followed by a pause. If you look at the middle of figure 22-9, you see there, if you go ahead and cut a piece of paper and then measure the P wave from P wave to P wave, it's supposed to be regular. Let's say P wave number 1, which is not really visible because it's cut off by the strip. But if you look at the first one, the first P and the not the first P, but the third P and the fourth P, they're regular, yeah. But then if you look at the third P, it occurred too soon, has a different interval. And it's easy to spot a premature atrial complex or even a PVC, a premature ventricular complex, because it's followed by a pause. Look at the middle of this figure. That's a pause, yeah? It's always followed by a pause. So a premature beat always is followed by a pause, a short pause, and then the underlying rhythm resumes. Okay? So when you see that on the rhythm or on the monitor, for instance, you see a pause, that's likely a PAC or a PVC. Okay, I'll show you PVC later. Now we're interrupted by the table with the drugs. So table 22-1. This table tells you the indication of the drug. Now, which drug am I testing? Unfortunately, all that is in table 22-1, because these are all the drugs that we use to treat dysrhythmias. Don't worry, because they are in classes. Okay, so because they are in classes, whenever it's the same drug class, do they have different actions? Do they have different side effects? Do we have different nursing responsibilities? The same. Yeah, this different, but the generics are similar, right? They all end in, let's say, for instance, with the 1A class dysrhythmias, what are they all end in? Okay, clindamide, disopyramide. Okay, they're similar sounding names. Okay, and then next row, 1B, lidocaine, 1C, leclinamide, propafenone, and so forth. So how many rows do we have there? Only 1, 2, 3, 4, 5, 6. Only 6 rows. So that's basically 6 classes. Okay, again, they share the same drug class, therefore the same side effects, the same nursing responsibilities. Any question?
No.
Okay.
And that's gonna be like 1A, 1B, 1C, the same one?
Well, I won't say 1A on the test question. I'll quote the exact name of the drug. So I say, when the patient is receiving prokinamide, what will the nurse watch out for?
Oh, okay.
Okay. Yeah, but I'll give you a tip. Now, most of these medications, with the exception of atropine, these medications do what to the heart rate? They lower it. Yeah. So that's a hint there. Meaning, do you have more tachy or more Brady dysrhythmias? No, no, no.
Wait, oh, yours.
You have more tachy type of dysrhythmias compared to Brady. Okay, so for Brady, we only have the sinus bradycardia and then the heart blocks. Heart blocks will be the last section for the dysrhythmia, so we'll get to that a little bit later. When you raise the heart rate, right?
Fair to say that every medication chart needs to lower the heart rate.
Most of them, yeah. Most, if not all. Okay. So if you look at class 4, you know, you're familiar with calcium channel blockers, yeah?
Yes.
Okay. Now, the calcium channel blockers, you know, are the DHP ones, which end in dipene, yeah? Nifedipine, amlodipine, nicardipine. These two are non-DHPs. These are the only two calcium channel blockers used for dysrhythmias. The other, the DHP calcium channel blockers that end in dipene are useless against arrhythmias. They're only used for hypertension. Okay, so these two are the only ones used for arrhythmias. Are we clear? So we use these for tachy, especially very effective for atrial fibrillation, atrial flutter with rapid ventricular response. These two are going to be used. All right. Intravenous. Although we can also give this PO for maintenance. I mean, when we discharge the patient. Okay, so let's finish the PAC. So PAC again, generally harmless. Okay, unless they occur frequently. But we typically don't see frequent PAC. I mean, when it occurs, it's usually caused by like someone drinking 6 cups of coffee, 6 cappuccinos. Yeah, that's when they when they start developing these PAC or PVC. Now, the only symptom the patient will feel is it looks like I'm skipping a heartbeat. Because if you look at again the figure 22-9, did the heart literally skip a beat? Yes, look at that pause. So did it skip a beat? Yes, there's a moment there that pause makes the patient have a sensation that their heart skipped a beat.
So theoretically, for some,
Right down the middle.
Again, I can't show you because
it's like halfway through the script.
Yeah.
So Professor, how is this like theoretically, well, in actuality, in the heart, what's happening with the PAC?
there was a premature excitation of the.
So without the atria being ready to.
No, actually, if you look at the shape of a PAC, it doesn't look like a normal P wave. So something else generated this impulse. This did not come from the SA node.
Okay, so this could be probably.
Yes, somewhere in the atria. Okay, caused again, triggered by whatever you were smoking.
It didn't release the blood, didn't pump the blood.
No, it did. It tricked the atria to contract.
Okay, so before it was.
Yeah, but this impulse did not come from the SA node. Something else fired the impulse.
Okay.
Causing the premature beat. And because of that, the heart kind of reset, not causing the pause, and then the patient feels it like it skipped a beat because it literally did. Okay. All right, let's go to the next more serious atrial rhythm, which is now AFib. Now we will discuss AFib together with atrial flutter because they're really identical. So let's start. What is atrial fibrillation? This is a very common dysrhythmia for people age 65 or older, meaning when we grow old, all of us are at risk for developing AFib. Okay, because age is the number one risk factor. Other risk factors are on chart 22-2. So number one, again, age, as mentioned. Next are the following: hypertension. Now, take note, hypertension can be caused by several factors, including any congestion inside the atria, which includes valve problems. And valve problems are actually mentioned here. Look at bullet number 5, valvular heart disease. Okay, so again, most of these conditions lead to increased pressure inside the atria, both left and right atria, and then causing some irritability, resulting in abnormal impulses. I'll show you the picture shortly. So right now I'm on page 699 for risk factors for AFib. So you have there from increasing age all the way to family history. Now, I won't test you on chart 22-3, but let's just discuss it briefly. Now, there are different types of AFib. When we say paroxysmal, description there is sudden onset, sudden also termination, meaning with or without intervention, this type of abnormal rhythm, this type of AFib comes on and then comes off on its own, with or without any intervention. However, you'll see the effects later. Let me go to the pathophysiology, and then I'll go back to that chart. I'm on page 700, right after the characteristics. You see the characteristics there that are in italicized, the ventricular and atrial rate, 300 to 600. Okay, are you with me?
Yeah.
Okay. After that, look at that paragraph that starts with patients with atrial fibrillation are at increased risk of heart failure. Are you following? I'm on page 700. Elisha, you find it? Are you on the textbook?
Yes. What you said, 700. Okay.
Right under figure 22-10. You see the AFib figure
Yes.
strip? Okay. Below that, okay, the next paragraph, patients with AFib are at an increase. Okay, right there.
Thank you.
Now, there are two effects here. If you look at the rhythm, let's look at figure 22-10. Do you see P waves? There are no P waves there. Okay, those squigglies you see there are not P waves. So therefore, since they're not P waves, is the SA node firing these impulses?
No.
No. Where did they come from? What's firing them? We have no idea. We don't know. Somewhere in the, no, that's not the AV node. Somewhere in the atria, some rogue cells are firing these impulses. Now, these are not, again, coming from the SA node. Something else is firing them, caused by, look at all the risk factors again, 22-2, chart 22-2, because of the increased pressure in the atria caused by these various conditions, led to the irritability of some cells in the atria. So we'll get later to the how to treat it, okay, especially the ablation. Now, as a result, again, look at the figure 22-10. So if the atria are not contracting because we don't see P waves, we see some QRS complexes, but they're abnormal, yeah? I mean, they're not in a regular rhythm, okay? So therefore, can you say that there's a different atrial rate here compared to the ventricular rate? Obviously, yeah, right? So we have a different atrial rate. We also have a different ventricular rate. So what can you say about blood movement between the 4 heart chambers? There's no regular movement, meaning every time there's contractions here, is blood really moving from one chamber to the next? No. So therefore, what's the first effect of this type of rhythm? What happens to cardiac output? It drops cardiac output because blood is not going anywhere. Maybe a little bit coming out of the aorta, but not normal in amount because again, they're not beating at the correct rhythm. And the atria, are they really contracting? No. The only true contraction is if we see what wave? There are no P waves here. So therefore, are they contracting? No, they're just doing this. Okay, the atria are doing this. So they're not truly contracting. So are they emptying into the ventricles? No. So that's the first effect. Cardiac output drops here. Second effect is because blood is not moving, what does blood do when it's staying in one
Plus.
space more than a few seconds? It will cause clots. So we have two problems here. One, cardiac output drops. Second, patient has a high risk for clots, which can cause a stroke, a heart attack, or a pulmonary embolism. Okay. So let's go back to chart 22-3. Regardless of the type of AFib, therefore, whether it's paroxysmal, persistent, long-standing, permanent, or non-valvular, what are the commonality? What are the common effects of AFib, regardless of the type? And high risk for clot. So therefore, management here, what will be the goal of management, knowing that these are the two consequences of this rhythm, regardless of the type?
Increase cardiac output.
We have to treat the heart rate. Yeah, we want to keep the heart rate within normal. So we're going to give these patients what type. So remembering the table with the medications, which medications will cause the heart rate to drop? Can we use calcium channel blockers? Yes. Okay, that's one option. Okay, so either beta blockers or calcium channel blockers. We don't decide. Okay, the doctor will decide which one because it will be based on the type of AFib the patient has. And what will be the second treatment?
Anticoagulant.
Because the patients are high risk for clotting. Okay. Now, which type of anticoagulant? Again, the doctor has to measure this. Again, it's not our decision. Okay, because the patient's risk factor is assessed, meaning if it's long-standing, that's why here, see, long-standing, continuing, lasting more than 12 months. So therefore, how long will the patient be on anticoagulant? More than 12 months. Okay, typically lifelong. You understand? Okay, so the doctor will have to weigh because it's not safe to put anybody on anticoagulants, is it? No, especially older people. Okay, they're high risk for falls and then they'll bleed, and then they'll bleed to death. So therefore, the decision to put someone on anticoagulants is really weighed against risk and benefits. Yes.
So, like, would someone, instead of, let's say being put on warfarin, would it be recommended to them to just take, aspirin daily? then?
Okay. The problem with that is you have to understand there's a difference between antithrombics and anticoagulants. Okay. So when you say antithrombics, they're really antiplatelets. That's the aspirin and clopidogrel. Those are antiplatelet drugs. So prasugrel, those same as clopidogrel. So they are antithrombics, meaning antiplatelet. Now, is a platelet a clotting factor? No, they're different. Clotting factors are proteins in the blood. Platelets are cells that clump together to stop a bleeding. So there are two different, right? So they're in two different pathways. So if you recall your clotting cascade, platelets are in the extrinsic pathway. Clotting factors are in the intrinsic pathway. Okay, so two different problems there. So can these patients benefit from antiplatelet? Probably not, because that's not.
They're still going to activate the clot.
Correct. Yeah. So antiplatelets are typically given to patients with coronary artery disease, artery problems, because now their arteries are weakened. They're very prone to rupture, and then clots form because of platelets. So therefore, we give antiplatelets. Okay? Correct, to prevent platelets from sticking there. This is a different problem because this is now a congestion problem. So now, because blood and clotting factors are pooling, so now you have And these are heavy duty clots because these are involving clotting factors now. These are clotting proteins, so they make fibrin clots. Unlike platelets, which are, are weak, these are strong clots. Yeah.
So, of the doctor, this is, type, which one would be the best?
Okay, well, we'll get to that next. Okay, so let's stay here. Just a few couple minutes. So the type of anticoagulant depends on the type. If it's non-valvular, let's start with the last one here on chart 22-3. If it's non-valvular, according to the drug company making these anticoagulants, they can benefit from 10A inhibitors. 10A inhibitors are those drugs that have XA in their name. So namely apixaban, edoxaban, rivaroxaban. All right, so these are 10A inhibitors. So they have been, based on clinical trials, they have been very effective for non-valvular AFib. What is non-valvular AFib? AFib not caused by a valve problem. Remember, when you have valve problems, is there pooling of blood? Yes, because either whether the valve doesn't open or doesn't close, congestion results. So therefore, valve problems can lead to AFib. But since this is caused by a valve problem, the only thing that works based on clinical trials is warfarin. But if it's non-valvular, clinical trials showed that the 10A inhibitors are excellent at preventing clots. But again, if it's valvular, clinical trials showed that the 10A inhibitors were useless. All right. So there's really no rhyme or reason. That's just because of the results of the trials. Okay. That's they can't explain it. You ask a doctor, they'll tell you the same thing. Oh, you don't know. The drug company said, that's their recommendation. All right. Yes.
Specifically for the baseline, that will specifically have to be based on.
Well, the key to using the beta blocker is if the patient has a high ventricular response. Because let's go back to the strip, the AFib strip, figure 22-10, page 700. If you look at that, now the key here is we'll call those wavy things F waves, okay? Because they're not P waves. We call them F waves, fibrillatory waves. Now imagine the chaos it would cause if remember the AV node? What was the job of the AV node?
Delay.
Delay, yeah. So it's a gatekeeper, yeah. And we said it's a secondary pacemaker. Now, this is the third function of the AV node. Now, the reason why this patient's heart rate is generally controlled. So let's imagine this is a 6-second strip, yeah? So what's the ventricular rate here? Estimated ventricular rate. 1, 2, 3, 4, 5. It's in the 60s, yeah? Okay, estimated 60s ventricular rate, which is normal. Now imagine if the AV node fell for each one, meaning here the reason why the ventricular rate is controlled is the AV node didn't fall for the F wave. So it recognized this is not an SA node impulse. Yeah, this is fake. This is an imposter. So did it respond? No. As a result, what's the heart rate? Which is between 40 to 60, right? From the AV node, AV node intrinsic rate. So therefore, this is evidence that the AV node is helping. The AV node is not falling for this farce, okay? They're not falling for this trick that this is not an SA node signal. Okay, so I'm not falling for this. So it's not responding to each wave. Because what would be the heart rate here? Estimate the heart rate. If it was falling for each one, this could be easily 160, 180, or even 200, 300. Yeah. Correct. Right. So if that's the case, if there is rapid ventricular response, then we should use beta blockers or even calcium channel blockers. However, if the rate is controlled and they're okay, then the patient will be given an antiarrhythmic. Remember go back to the
In that chart.
right. Now the patient would be on, let's say amiodarone, or let's say flecainamide, okay, or propafenone. These are the choices, okay, to convert, because these guys convert the rhythm. Okay, they're effective in converting the rhythm. Although it doesn't work for everybody, but the doctor will put them on these for a trial and then see if it works, especially if it's new onset AFib. But for persistent, long-standing, these are resistant to any antidysrhythmics, meaning these AFibs don't convert ever anymore. So for paroxysmal, you have a chance to convert it. But for persistent, long-standing, permanent, these are hopeless. They're going to be AFib forever.
Mm.
Okay,
But if they're AFib and you give them beta blocker,
we can just control the rate, because there's
Wouldn't
nothing
it
we
be
can
Brady?
do with the rhythm, huh?
they wouldn't become Brady.
No, as long as the dose is, I mean, sometimes it can go Brady, and then the doctor would just change decrease the dose. So any question on AFib? All right, let's look at the other options. So let's say the patient is old, 80, 90. Is it safe to put these patients on anticoagulants? No, because they fall, right? They fall, hit their head, bleed to death. Okay, so for those patients, there are non-pharmacologic options. One is, let's go now to the last paragraph before assessment and diagnostic findings. So we have here left atrial appendage occlusion, meaning, let me show you. Oh, I can't, I have no screen. So not all people have a left atrial appendage. What it is it's like a little extension of the left atrium. So think of it as, you've seen a river, yeah? Have you been at a riverbank? Okay, so by the riverbank there are rocks there, yeah? And then there's water that are sometimes caught in certain rock formations. And that water, can it move? It's stuck there, yeah? And then that water, therefore, is it clear? No, it's kind of cloudy, yeah? Because it's already, yeah, it's been there for a while. It doesn't move because it's caught in those rocks. So think of the appendage as that part of the riverbank. So therefore, some blood gets stuck in that appendage, and that's usually where the clot forms, in that left atrial appendage. So if the patient has that, then they'll close that appendage. They'll put a patch there, a mesh. So therefore, no left atrial appendage. Is there anywhere for the clot to form? No. So that's a non-pharmacologic option. Another is, let's say the patient has multiple blood clots already, meaning they've had more than one pulmonary embolus because of this AFib, and they're not a good candidate for anticoagulation. So the doctor will offer, okay, let's put a filter in your inferior vena cava. So it's like an umbrella. You've seen the sticks of an umbrella, no canvas. Yeah, just the sticks. Okay, so they put it in the inferior vena cava, anchor it there, and then it will catch blood clots. So it's 98% successful. Why 98? Because what about the superior vena cava? Okay, although most clots form from below the body, so no, it can't. It prevents most clots, and again, 98% successful, but there's a 2% failure rate. for those very rare clots that form above the body. But I mean, I'll take 98%. Yeah. Okay, so for manifestations of AFib, again, what are manifestations of low cardiac output? Okay, lightheadedness, yeah? And then will there be, whenever your cardiac output drops, will there be a reflex sympathetic response? Yes, then palpitations will occur. Shortness of breath. Okay, so those are, and then the manifestations will now, if there is embolization now. So let's say the patient did form a clot in the heart. So now we have stroke signs and symptoms, heart attack signs and symptoms, pulmonary embolism signs and symptoms. Okay, so PE, stroke, and MI are all fifth semester topics. I can't discuss them here in this chapter, and I won't test you either. So we've discussed the management already. So the drugs we spoke about earlier. Now these are page 700 still under medical management. Now here are some non-pharmacologic options. These are beneficial only for new onset AFib, meaning, yeah, so this is new AFib, okay? So options are number one, rhythm control. So this is using medications, see if they respond to propafenone, okay, flecainamide, those heavy duty antidysrhythmics to convert the rhythm. If that doesn't work, and the patient's but the patient is still within 24 to 48 hours, okay, from onset, so these are very effective. However, if the patient here, it continues severe heart failure and the atrial fibrillation has been, going on longer, then it's considered permanent already. Now, one option for new onset AFib. So let's say the patient, because if you look at the risk factors, did you see pregnancy here? Not pregnancy, but let's say no, it's actually, well, because it sometimes happens in labor. That would fall under exercise, I guess, okay, when the patient is in labor. All right, so let's say it happened during labor. So it's sudden onset, right? Acute onset AFib. So go back to page 700. Let's look at the cardioversion. You know what? Cardioversion is in a separate section, so I'll come back to that. So these are the drugs. So we said antithrombics. So what are antithrombics again? Aspirin and clopidogrel. Okay. Next set of drugs we have. The decision again is not for the nurse. Okay, we're not deciding. The doctor will prescribe whatever treatment, and our job is to do the teachings. Okay, regarding whatever the doctor prescribes. So here are your, for anticoagulation, the target depends on the patient's risk factors. The patient already has, let's say, they have a mechanical heart valve. As I mentioned, what's the only option? Warfarin. Nothing else will work. So if it's involving any valves, especially mechanical heart valve, only warfarin. There's no other choice for you. And the target for that would be 2 and 3. Meaning the patient has a mechanical heart valve and you have AFib because of that, then the target INR is quite high. 2 to 3 is high. Now for PEs, the patient has 1 or more PEs, it'll even be higher. 3 and 4 is the target. So these patients are very high risk for bleeding because of that. For DVT, usually the target is 1.5 to 2. So it's lower because the risk is lower. So medications to control the heart rate. We mentioned calcium channel blockers, beta blockers. And we have the next one, options to convert. So these are the drugs used to convert. Lecanemide, dofetilide, propafenone, amiodarone. Okay, we mentioned some of these earlier already. So the goal for these is to convert the rhythm. This is again only for new onset. Okay, these will not be effective for persistent, long-standing AFib. I mean, it's useless. But what for? No, I'm on the paragraph. I'm on 701 now. Remember, we started with drugs, antithrombics, and then now we've got medications to control heart rate, medications to convert the rhythm. Okay. Okay, here's cardioversion. Now, cardioversion is different from, this is different from defibrillation. However, the equipment used is exactly the same. You've seen a defibrillator, yeah? Because you're in clinical. Have you been to the crash cart? So you've seen what a defibrillator looks like? Okay. So if you observe closely or the next time you go to clinical, go to the crash cart, look at the defibrillator and look for the synchronize button. There's a sync button and SYNC. Okay, so when the sync button is on, that defibrillator becomes a cardioverter. Again, the equipment's the same. So if the synchronize button is off, the machine is a defibrillator. If the synchronize button is on, it becomes a cardioverter. Now, the difference between the two is the timing of the shock. If it's a defibrillator, the shock will be delivered whenever the user presses the shock button. You press the shock button, boom, the electric shock will be given. If you turn on the synchronize button and then you press the shock button, the shock will not be delivered right away. It will be a few seconds later because what the machine does is it will synchronize with the patient's rhythm first. So it'll take a few seconds, a few moments, and then it will deliver the shock at the peak of an R wave. Unlike defibrillation, when does the defibrillator deliver the shock? Whenever the user presses the button. If you turn on the synchronize button, what will it do? Synchronize first and then time the delivery at exactly the peak of an R wave. You know what an R wave is, right? It's that pointed thing on your heart rhythm. It will deliver it there. Once it delivers it there, 8 out of 9 times, 8 times out of 10, it will convert the rhythm back to sinus. Again, it's very successful. Most cases, if used appropriately, okay, meaning the candidate, the patient is a good candidate for cardioversion, selected carefully and then done at the correct time, within the 24 to 48 hours or even less from the onset of AFib. Yeah, so or also a flutter. So in the ER, this can be done in the ER, meaning just happen, and then we're sure, oh, new onset, patient's a candidate, they'll do cardioversion. Now, how is this done though? So in defibrillation, what was the patient's condition? Was the patient conscious? No, because you've done BLS. BLS, we do cardioversion, the patient is pulseless, yeah? Pulseless and breathless, yeah, unconscious. So will they feel, are they aware when they get the shock? No, no idea. They're unconscious. Yeah, they have no idea what's going on. In cardioversion though, is this patient dead? No, this patient is in AFib. So therefore, let's say, imagine this is Rebecca. Rebecca, you're in AFib, okay? And they tell you, okay, we can do this. We can convert you. Okay, so what we'll do is, turn on the synchronize button. We'll give you an electric shock. Okay, you good? So what are you gonna do? Hold on to something? Get a stick? Oh, very on a stick? Okay, hit me. Is that the scenario? No, we have to sedate you because, yeah, because this is like you've seen Taken, the movie Taken? No? Liam Neeson electrocuting that guy who kidnapped his daughter? That's what's gonna happen. So therefore, we need to sedate you. Okay, so we'll give you a mild sedative, you'll be out, and then we'll do the cardioversion.
Boy.
Or you can choose, okay, no, hit me. I'm Rambo. Yeah? Or John Wick, right? So yeah, we sedate the patient. So this is scheduled, okay? Defibrillation was, did we schedule that? Okay, well, this, okay, 1 o'clock, everybody be here. We'll defibrillate Samuel. Okay. No, this is all random, yeah. But cardioversion, this is scheduled. Okay, let's do it. Okay, in 5 minutes, let's do it in 5 minutes. All right. This is planned. Okay, we already know about the okay. When the patient is new onset AFib, so no need for anticoagulation because it just happened. Okay, it just started. However, if the patient's been on AFib for let's say a week, they're still candidates for cardioversion. However, is there a chance that there's already a clot there?
Yeah.
Yeah, because it's been a week. So therefore, when we do cardioversion in that scenario, there's a clot. Could we dislodge the clot?
Yeah. Yeah.
Yes. So therefore, if that's the case, we can't do the cardioversion until we're sure that there's no clot. So how do we know whether or not there's a clot there? What test do we need? An echo. So we do an echocardiogram, look at the heart, literally look at the heart chambers. Let's find a clot there. No clot. Okay, let's do this. Okay. All right. So let's say it's been several weeks. Now the patient has to be on anticoagulant for at least 4 weeks. And then come in for an echo and then do the cardioversion. All right. Meaning all in the, because again, the procedure could dislodge a clot. So therefore, if it's that long already, like we had an instructor before who had new onset AFib, and this is what she had. So she was put on warfarin for 4 weeks, and then she came in for echo that day, and then they did that cardioversion.
So the cardioversion could be done at any time.
Yeah, as long as it's new onset AFib.
Unrelated, someone who is like still menstruating and on like they are at risk for menstruation.
No.
Oh, so it'll be not.
No, it won't, because it doesn't affect the hormones.
Okay.
Okay, it's just, but I mean, you bleed more than usual, but
Okay. It won't be hemorrhaging.
possible.
Oh.
Okay, last procedure is the ablation therapy. Ablation means destruction. Okay, so remember earlier what was firing those F waves? Was it the SA node? No, it was some rogue cells in the atria. Do we know which ones?
No.
No. So before we can destroy them, what did George W. say for Katrina? Sir, Mr. President, what are you planning to do about Katrina? What did he say? He said, we're going to find her and we're going to bring her to justice. Yeah. Okay. So we'll do the same thing here. For before we can burn and destroy what's causing the AFib, those cells, we have to find them first. So we're going to take the patient to the EPS lab, electrophysiology lab. Who works in big hospitals here? Like Montefiore, Bellevue. You have EP labs, right? Electrophysiology labs. It's in the cath lab.
Yeah.
Okay. So if you have a cath lab, you have a EPS lab. Okay. So EPS lab will locate. So we'll put 1,000, not really 1,000, a few, a couple dozen electrodes, okay, to your heart, and then we'll find them. Okay, they'll see, they're the suckers. Okay. So when they see them, and then they'll take you to the cath lab, thread the catheter with a cautery tip, and then they'll destroy them. Bam, 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 burn them. Yeah, electrode, cautery tip. So literally burn those suckers. The problem, possible complication for that is we may, especially the SA node. Yeah, so if we damage the SA node, then the patient, no, they will
That's
die.
boring line.
So no more SA node, so the patient will require a pacemaker. Okay, so therefore, can a patient with AFib be treated with a pacemaker? Technically, no, but can they have one? Yes, as a complication of this procedure. Because if they undergo ablation, there's a chance we burn the SA node. And then now they require a pacemaker. Okay, but we didn't intend to, but they signed consent,
That
Like the
was-
thyroid, you damage the thyroid to give them level thyroid.
yeah.
What's the
That makes sense.
percentage of patients that end up having that?
Oh, there's always a chance.
Well, I know, but is it like, like, we know it can happen, there's always that chance, but like what percentage of patients?
I have no idea.
Those are like less than.
I mean, I don't work there, so
1% or,
no idea.
got it.
Okay, so that's the EPS. We'll skip the maze and mini maze procedure conversion. That's very rare. Left appendage, left atrial appendage occlusion. So we described that earlier. Oh, we have a picture there. Figure 22-11, page 703. You see the Watchman there?
Yeah.
Okay, so the Watchman is the number one, or I should say, most popular device for LAAO. Okay,
That's
Watchman.
occlusion.
Yes, they put a mesh there. See, they eliminated the appendage.
With that one,
This,
they have
the
to be
whole,
on
the whole shit's blocking the whole.
No, this is indicated if the patient has a contraindication for, meaning not safe to take anticoagulants. So this is the only option. No, they closed it, so impossible to get a clot because it won't fill with blood anymore. They closed it off.
Tension, right? So the clot-
No. It blocks it. See, it like caps totally blocks the appendage. So therefore, no blood can enter that anymore. So no blood can enter, no clot can form.
Isn't it easier just to clamp it off?
I mean, it's kind of complicated because you have to do, open heart surgery. Watchman can be done minimally invasive.
Last question, the one that you said, inferior vena cava,
The filter.
tension. After a while, the clot starts to dissolve.
No, because the body naturally dissolves a clot, meaning as soon as a clot is formed, we start breaking it down. So it just sits there until the body breaks it down. Any question on AFib? Okay, let's do A-flutter and we'll take a short break. A-flutter, this is quick because this is same thing, just looks different. Comparing AFib though with atrial flutter, look at figure 22-12. Does it look better? Actually, it looks more organized compared to the AFib. AFib is very irregular. This one is, so they call it sawtooth appearance.
Yeah.
Okay, so look at that. Look at how many flutter waves there are. 1, 2, 3, 4. Okay, so there are 3 flutter waves before the QRS. So it very regular. It has a pattern. But again, are these P waves? No, they are flutter waves. So if you're in A-flutter, AFib, same exact effect, same consequences. Is there decreased cardiac output?
Yeah.
Is there clotting?
Yeah.
Yes. So treatment is the same, so we won't repeat it.
So same onset, like if it's less than a week.
Same.
The medicine.
Right. Same risk factors, although we have more cases of AFib compared to A-flutter. All right, let's take a break, and then when you come back, we'll jump to the ventricular dysrhythmias. Okay, we'll stop at A-flutter for atrial dysrhythmias. Come back at 3 o'clock.